introduction and the opportunity to share my thoughts from Sydney on the off-the-shelf options for thoracoabdominal aneurysm repair. Really, the device that we're talking about is the Cook Medical T-branch device, which is well outlined there in that image on the left. It has a proximal diameter of 34 millimetres, 3 sealing stents. The celiac and SMA branches are just offset from each other, and they're 8 millimetres in diameter, and the renal branches are 6 millimetres in diameter. And then there's the infrarenal component, which can be married up with a variety of off-the-shelf options to achieve a distal sealing zone. So what sort of patients would be suitable for treatment with this device? Well, firstly, you need to have adequate access, and there needs to be a proximal landing zone which is at least 20 millimetres in length and 40 millimetres in diameter or greater. There needs to be a luminal diameter where the branches are going to open up of at least 25 millimetres, and in terms of where the cuff lies to the origin of the intended branch vessel target, ideally there's 15 millimetres of length and less than 90 degrees of deviation. If there's a shorter distance then from the renal cuff to the aortic bifurcation of less than 67 millimetres, that can pose difficulties, and that can be a problem when you have an old surgical graft in situ. If the distance from the celiac artery to the most caudal renal artery being greater than 56 millimetres can be a problem. And then there can be issues in regards to target vessel concerns, including upward-facing target vessels that are too small, an early branching pattern, and of course the problem of having multiple renal arteries. In larger series, the applicability of this graft for treating conditions of the thoracoabdominal aorta has been found to be pretty good. Somewhere between 40 to 70% of patients are suitable in the elective setting, and that drops down a little bit in the urgent or emergency setting. My own personal experience with branch thoracoabdominal, we wrote up about 6 years ago with our early experience, and it was the first and really only Australasian publication on the technique, but it included, in fact, the first in the world off-the-shelf T-branch, which I was lucky enough to be involved with as a proctor in New Zealand. And if you look at firstly, that patient had a 10 centimetre thoracoabdominal aneurysm treated in September 2011. That patient went on to achieve a reasonable survival with over 4 years. And if you look at the other patients treated in that series, the first one, the 6th one, 7th one, 9th one and 10th one all achieved reasonable long-term survival. So the technique itself, as we know from this experience and many others, has good medium and long-term results for patient care. So what sort of patients would benefit from an off-the-shelf T-branch device? Well, this is one case from my own experience. It's a 72-year-old woman who had a sudden onset of interscapular pain with a family history of sudden death and a normal blood pressure. They had a CT at presentation showing a significant intramural hematoma extending along the length of the thoracic aorta with the appearance of ulceration into it. The patient had ongoing pain, and conservative management did not seem to be an option. So I went on to perform carotid subclavian bypass and TEVAR and decided to land the graft in the mid-descending thoracic aorta to try to reduce the chance of spinal cord injury. The patient went home successfully and then represented with pain. The repeat CT scan showed patency of the carotid subclavian, good positioning of the TEVAR graft, but at the distal end of the graft there'd been a new entry into the